Hi, everyone. Thank you for joining us today. My name is Sarah Burris. I'm the scientific liaison here at FUJIFILM VisualSonics, and we're very happy to present the next webinar in our installment by Dr. Jana Grune and Niklas Hegemann. Both of them are from the Institute of Physiology at Charité University in Berlin, Germany, and they will be talking to us today about From Bedside to Bench, the applications of lung ultrasound in small animals. So just a few notes about our webinar. We are recording this webinar and a recording will be made available within the next week. All of our participant lines are muted for the duration of the webinar. So if you have a question, please use the Q&A button located at the bottom of your screen. Questions will be answered at the end of this session, and you can expect the webinar to run approximately 30 to 35 minutes, and we'll have 10 to 15 minutes afterwards for the questions. So just a few notes about our presenters. Dr. Jana Grune earned her PhD in 2015 in pharmacology from the University of Potsdam, located in Potsdam, Germany. Her work at that time focused on the effects of non-steroidal mineralocorticoid receptor antagonists on cardiac hypertrophy. Since then, she has worked as a research assistant and scientific coordinator at the University of Berlin and Charité University in Germany. She's currently a research assistant at the Center of Systems Biology at Harvard Medical School in Boston under the direction of Matthias Nurendorf, where the lab focuses on the role of immunity in cardiovascular health and disease, where they specifically focus on atherosclerosis and heart failure. Niklas earned his master's in science and novel therapies in 2018 from Imperial College London in the UK. His work at that time focused on the characterization of CPXM2 and its involvement in heart failure using a zebrafish model. He's currently a research assistant and PhD candidate at Charité University in Germany, where he specializes in small animal echocardiography and invasive hemodynamics. So with that, I will turn it over to Dr. Grune and Niklas.
Thank you, Sarah, for your kind introduction, and also a warm welcome from our side, Jana and me, Niklas, and welcome to today's webinar, From Bedside to Bench, application of lung ultrasound in small animals. Before we dig into the actual presentation, I will give you a short overview of our agenda for today. Firstly, I will give you an introduction into lung ultrasound. So I will be talking a bit about the physical rationale of all those different artifactual patterns that you're going to see today, and which are actually associated with pathophysiology, with different pulmonary pathologies, and which are associated with normal healthy lung. Secondly, Jana will talk a bit about clinical application of lung ultrasound before I will take over again for a guide to small animal lung ultrasound. So I will really just give you a brief introduction into how we perform lung ultrasound at our lab. And then we'll have two different small animal models where we actually applied lung ultrasound. The first one being a rat model of left ventricular failure, and secondly, a mouse model of valvular heart disease, which Jana will be presenting. Finally, we'll have some closing remarks, and we'll then be open for discussion and open to your questions. Just a final reminder, at the very bottom of our slides, we'll have this green box, which will guide you through our webinar today, and will keep you up to date where we are with our webinar. So let's start with some basics about ultrasound and lung ultrasound. So ultrasound in general has been in place now for several decades, and it's been appreciated for being non-invasive, obviously radiation-free. Thirdly, it's bedside performable, definitely an advantage over other imaging modalities like CT scan or MRI, and has definitely a high diagnostic accuracy, especially in the setting of lung ultrasound. That's something we'll be picking up on later. So let's start with the very basic principles of lung ultrasound. So if you have a look at the right side of the slide, normally, for example, in echocardiography, you will get an anatomically correct depiction of your target organ, the heart. You can appreciate at the bottom of the slide a B-mode image perched on a long axis view of the heart. You can see the left ventricle, the left atrium, the aorta, a portion of the right ventricle, and also you can see the aortic valve pretty nicely However, if you have a look at the left side with lung ultrasound, you will mainly get artifacts. If you look at the ultrasound image on the left bottom side of the slide, you can see that there's mainly some wide horizontal hyperechoic lines, some shadowing, and we'll be talking on the next slide about what this actually causes. So first of all, excuse me for the AT style transducer probe here. Basically your transducer will be applied to the chest of your small animal or of your patient. If you now turn over to the right side of the slide, the ultrasound probe will then emit ultrasound waves. Please go back one slide. Your transmitter or transducer will emit ultrasound waves, which will then firstly hit the skin, which can be easily penetrated, and will then hit different structures, for example, like the ribs. The ribs as a pretty dense structure, bone as a dense structure, will reflect the ultrasound waves and will therefore cause ultrasound shadows on your screen. However, if you look at the middle portion of the schematic, you can see when ultrasound waves penetrate further into subcutaneous tissue through pectoral muscle and also intercostal muscle, it will reach the pleura, a structure which is also pretty dense and will reflect ultrasound waves. However, not always will the ultrasound waves be reflected directly back to the transducer, but sometimes it appears that you will have some bouncing back and forth of ultrasound waves. So some portion of the ultrasound waves emitted will reach the transducer back only with a temporal delay. And what that basically causes on your ultrasound screen will be shown in the next schematic. So you can appreciate in the top part of the ultrasound image basically a wide horizontal hyperechoic line which represents the pleura. And then just underneath you see those so-called A lines, which are basically just multiple reflections, so-called reverberations of the pleural line. So basically, due to this temporal delay of the ultrasound waves reaching the transducer back, this will give the idea that there's some structures deeper down in the tissue when that's really just multiple reflections of the pleural line. And in between these A-line conglomerates, you can see the rib shadows that I just mentioned a second ago. Now we'll talk a bit about different artifactual patterns that you can detect that are associated with different pulmonary pathologies. So on the top left-hand side, we'll start with our very normal healthy lung ultrasound image. So just above the pleural line, which you can see here nicely, are some horizontal lines, which here represent, again, some subcutaneous tissue, pectoral muscle, and intercostal muscle. Then we'll have the pleural line, and just subpleurally, we see are nicely stacked up on another A lines with the rib shadows in between. So the first artifact that we'll be talking about are the so-called Z lines, which are short comet-like artifacts that are rising downwards from the pleural line. They do flicker on the screen, and they do not move jointly with what we call lung sliding. So lung sliding is really a shimmering appearance of the pleural line, which goes in concert with respiration and movement of lung tissue. So overall, Z lines are classified as non-disease associated and seem to have no clinical relevance. There are some discussions going on about that, but from our side, we don't take note of Z lines as a pathological finding. However, with B lines, it's a completely different story. So they're unanimously considered a pathologically finding. They are basically these very long comet-like artifacts arising also downwards from the pleural line. They actually stretch towards the very bottom of your image, and they're caused by thickening of interlobular septa. This might be caused due to edema or also due to ground glass lesions, and either of the two will actually alter the acoustic impedance of the lung tissue and therefore cause these very tightly spaced lines, which have an appearance like basically a laser beam or a sunbeam. And they are definitely most of the time associated with pulmonary edema. Then going on to pleural defects, this states basically in discontinuation or some irregularities of your otherwise very distinct pleural line. This can be either caused due to a focal fibrotic lesion or also due to starting consolidation of lung tissue. And what you would always, or at least very often also see, is B-lines arising downwards from this defective area. Going on to pleural effusion, so which is basically a fluid-filled black swollen pouch that will appear on your image, as you can see here, which will allow for the discrimination between the parietal and visceral pleura, something that is in our healthy image not possible, because visceral and parietal pleura will be just lying on top of each other. And with this black swollen pouch, fluid filled, it allows for the discrimination between the two. So this is very often seen with more severe cases of heart failure. Finally, we have pleural thickening, which is pretty straightforward, a thickening of the pleural line. Very strikingly, that pleural thickening appears to be much more diffuse. So the pleural line gets really diffuse in contrast to your normally very clear, sharp, distinct pleural line. Furthermore, if you put an M mode across your B mode lung ultrasound image, something that you can detect is the so-called Seashore sign. So basically, what you will see with this motion mode is suprapleurally a more static image. So you just see some lines, which again represent subcutaneous tissue, pectoral muscle, intercostal muscle. Then you will have your very distinct wide hyperechoic line, and then this dotted pattern that appears in the subpleural area of the image. So this sandy appearance, that's basically why it's called Seashore sign, is caused by movement of the pleural line, this so-called lung sliding, and therefore, since the A-lines are basically just multiple reflections of the pleural line, these A-lines will move also and cause this dotted pattern that you can see here. And this is something that you would want to see with a healthy individual. However, there's also a second pattern that you can detect, the so-called stratosphere sign. So you can see here clearly that you will have a continuation of this line pattern in the subpleural area. And this is basically caused by the fact that you will not be able to detect with lung ultrasound anymore this lung sliding. So this will be abolished, and therefore, since you don't have any movement that can be detected along the pleural line, you won't see anymore this dotted pattern that indicates movement in the subpleural area of this image here. And as you can already guess, this is associated in most cases with the diagnosis of a pneumothorax. And there I would like to hand over to Jana for the clinical applications.
Thank you, Niklas. Okay, so let's talk a little more about the clinical application of lung ultrasound. As you may know, the lung has traditionally been excluded from the ultrasound organ repertoire, and therefore the application of lung ultrasound in the clinics was largely limited to a few enthusiastic clinicians. Personally, I know from my own experience that at the first sight, lung ultrasound images may appear a little complex and also unintuitive, but this notion should definitely be outweighed by its demonstrated clinical usefulness and will hopefully also be the case for future research applications. So for clinicians starting with their lung ultrasound training on usually critically ill patients, the basic skill level is generally acquired over a very short period of time, meaning it is very easy to distinguish diseased lungs from normal lung physiology and also morphology. So once the process has been learned, a kind of step-by-step approach enables the implementation of lung ultrasound into the clinical routine. And this implementation is not only limited to the ICU, which is of course at the moment the main department using the lung ultrasound technology as a kind of a diagnosis tool, but it also extends to other clinical scenarios like the clinical cardiology department. So as of by now, a series of studies has already shown that lung ultrasound is not only able to diagnose several lung diseases like pulmonary edema, pneumonia, asthma, congestion, but it can also be a useful tool to distinguish and differentiate these diagnoses against each other, and can also further contribute to adequate therapy and treatment of these diseases. The advantages of lung ultrasound can be appreciated by comparing it to distinct other imaging modalities which are typically used to image the lung. So namely the chest X-ray and also the lung CT. The lung CT is the gold standard method, and because it has the highest diagnostic value so far, but it is also very costly and time intense. It requires a supine positioning of patients, and it also exposes these patients to irradiation. In contrast to that, the chest X-ray is most commonly used and also widely accepted, but it has a lower diagnostic value and is also limited with regards to its bedside performance. So when compared to CT and also chest X-ray, the lung ultrasound is almost equivalent in detecting the main lung pathologies, especially in patients with ARDS. So it is bedside compatible, which is especially important for unconscious critically ill patients. And it can also be performed very quickly and produces lower costs than the other two imaging modalities. And this makes the lung ultrasound a very useful tool for the rapid bedside diagnosis of lung pathologies. To give you at least one example of the application of lung ultrasound in the clinics, I would like to briefly mention the groundbreaking study of Lichtenstein and colleagues, which became known as the so-called BLUE protocol. And the BLUE stands for the Bedside Lung Ultrasound in Emergency. And what this study is basically doing is comparing lung ultrasound results of patients with dyspnea with the final diagnosis made by the ICU team using the traditional lung imaging techniques like CT and also chest X-ray. And all of this was done to assess the potential of lung ultrasound to diagnose acute respiratory failure. So what the authors of this study did is they developed a kind of decision tree for diagnosing lung pathologies by using only 3 signs of lung ultrasound to discriminate these patients' cohorts. And if we now look at this decision tree here, so for example, if a patient presents with lung sliding, so the lung is still properly moving in this patient with expiration and inspiration, but this patient has also multiple diffuse B lines, which is according to the BLUE protocol, the so-called B profile, which would be the very left arm of this BLUE protocol here. This patient would be diagnosed with pulmonary edema. And when the authors compared their diagnosis to the final diagnosis made by the ICU team, the lung ultrasound was able to diagnose pulmonary edema with 97% sensitivity and 95% specificity, which are, I guess we can all appreciate that, very good results. So to sum this up, the overall rate of correct diagnosis with lung ultrasound is around about 90% when compared with conventional diagnostic tools. And this makes the lung ultrasound a very useful tool to for the rapid assessment of a broad variety of lung diseases in the clinics. So in the next couple of slides, Niklas will tell you a little bit more how the lung ultrasound works for small animal models.
Thank you, Jana. So as you can already see on these images here, we're not showing you actual animals for a number of reasons, but we rather use our VisualSonics mascot, which does a perfect job here. So you would want to have your small animal in a supine position. In this case here, under isoflurane anesthesia, you will have ECG control to monitor heart rate, a rectal temperature probe to monitor temperature, and as well the respiratory rate. The ultrasound probe, in our case an MX400, should be directed in the area of the anterior axillary line, and the upper proband should be at the level of the axilla. If you now turn to the right side of the slide, you can see that our imaging table is tilted to the right side, 15 degrees. The ultrasound probe is angled at 60 degrees, so you will end with a 45-degree angle between the imaging table and the ultrasound probe. This is just because lung ultrasound as part of our echocardiography routine just comes prior to the aortic arch view, and this is just convenient for us. That's why there's this tilting to the right side. And then what you would want to see is something like this. So this is our Vevo 3100 workstation that we use for ultrasonography with our small animals. And this is this very nice A-line profile that we talked about before. So we see in the suprapleural area subcutaneous tissue and some more tissue pattern that represent pectoral and intercostal muscle. We see some dark shadows, which are the ribs. We see our nice, very distinct hyperechoic pleural line. And then just below, we see our A-lines, which are stacked upon another. And here are some presets that we use with the lung ultrasound in our small animals. So you should have a frame rate of 200 frames per second. The gain should be adjusted to 20 decibels. Depth should be adjusted to about 8 to 10 millimeters beyond the pleural line for mice. The depth is really not that important if you're just looking whether your individual has a or B line profile, but especially if you're looking at pathologies where you would want to expect some, for example, consolidations deeper down into the lung tissue, you would probably adjust the depth a bit more. And obviously for rats, you should also increase the depth a bit. For our mice, as I just mentioned, we use the MX400. For our rats, we use the MX250. Going on, we'll now introduce you our two small animal models where we actually apply lung ultrasound. So the first one is a rat model of left ventricular failure. On the right side, you can appreciate some sinoloops, B-mode peristernal lung axis view. You can see that in the top sinoloop, we have a weaker contraction. We have definitely some left ventricular concentric hypertrophy going on. If you now turn over to the left side, you can see in the quantification at our 3 time points of 3, 5, and 9 weeks, we see a significant differences in the left ventricular ejection fraction. We see an increase in left ventricular mass, and accordingly, we also see thickening of the left ventricular anterior and posterior wall. And this is what we can see with lung ultrasound and our LVF model. So in the control animals, we basically get, again, this very normal pattern that we talked about multiple times now. So you can see this very nice hyperechoic line, the pleural line in the top part of the sinoloop, and then just below, very nicely stacked up on another, these A lines. We do see some shimmering across the pleural line, which indicates lung sliding, and we actually see some Z lines flickering. We don't pay attention to that. We talked about that before, so that looks pretty normal. However, with our LVF animals, it's a completely different story. So if you have a look at the left sinoloop of those two, you can see that there's a massive black swollen pouch that has formed in the pleural cavity. So that's basically a massive pulmonary effusion. We can discriminate between parietal and visceral pleura. The visceral pleura looks actually a bit thickened. We can see multiple B lines arising downwards. If you then turn over to the right side a bit, you can also see some defective areas along the pleural line. We see some B lines arising downward from that. The right image shows you a pattern that we call a white lung. So basically, the complete screen is covered by B lines, and you can also clearly see that the pleural line is pretty diffuse. So that's definitely something that we would call pleural thickening. So you can definitely see here that we can detect a variety of different disease-associated lung ultrasound artifacts here. But then the question really is, how do we quantify these images? So in 2017, Villalba Oreiro et al. Have published a mouse lung ultrasound score, which we have applied to our rat model here. And as you can see, we can see some tendencies going on between our control and our LVF group at the different time points. However, we couldn't pick up any significant differences. We also did some correlations to some functional parameters of the left ventricle, so the ejection fraction and cardiac output, as well as of the right ventricle, looking at TAPSE. What we could detect here was moderate correlations, so nothing too overwhelming, to be honest. So that's why we started to look into creating a novel scoring system for our rats, which actually performs way better. So we picked up on a number of parameters that have been used previously. But also we added some parameters that we'll not disclose here today for several reasons. But you can definitely appreciate that the data points have come together and we were able to detect significant differences at all 3 time points. Looking at the bottom part of the slide, you can also see that our correlations have increased drastically. So for EF, are of 0.66, for cardiac output 0.75, for TAPSE 0.72. So that's some data that we're really enthusiastic about, and this is something that we're preparing for publication soon. And with that, I would like to turn over to Jana for the second model.
Thank you, Niklas. Yeah, so as the second model, preclinical model for the application of lung ultrasound, we use this time a mouse model of valvular heart disease. So these mice suffer from aortic valve stenosis, and this leads very early regarding to their lifespan to the so-called valvular heart disease phenomenon. So as you can easily appreciate from the images on the upper part of the slide, we are seeing here B mode images and M mode images of the left ventricle. These mice have a huge left ventricle and also one which is failing. So the left ventricular ejection fraction is dropping down already in living week 12 of these mice. And also the left ventricular mass is highly significantly increased compared to wild type age-matched controls. Because this phenomenon is or was observed so early in life, we thought about looking at the right ventricle of these mice and if this one is probably also affected by the left ventricular failure. And because this has been seen in the clinics as well, and is the phenomenon of the so-called secondary pulmonary hypertension. So if the right ventricle is failing, it's most likely that there's also something going on in the lung. And I don't want to go here into too much detail, but typical parameters characterizing the right ventricular function like TAPSE and also the right ventricular ejection fraction are also decreased in these mice. And this prompted us to apply the lung ultrasound here to this mouse model as well. So on the upper part of the slide, you can see the cine loops of these mice. So we have wild type controls, and this is what Niklas already showed you here. I don't want to go into too much detail anymore. We see the pleural line, nice lung sliding here, and compared to the mice suffering from aortic valve stenosis, this is a complete different image here. So the middle one shows you a mouse where this lung disease is not that far progressing at the moment. So we can see some emerging B lines. The pleural line seems a little bit thickened and there's not really proper lung sliding anymore. But on the right side, this is really one where disease was progressing already a lot. So probably 75% of the image are covered by the B lines. So it's a so-called B profile. The pleural line is massively thickened and we do not have the proper lung sliding anymore. And all of this can also be observed in the lower part of the slide where we have just the images from the cine loops and with the landmarks. So if we now quantify this data using the mouse lung ultrasound score, this is also reflected in the quantitative data part. So the progress of the disease over time can be observed by using the mouse lung ultrasound score. And this is here shown by the increased mean values of the mouse lung ultrasound score. So we are almost at the end of our seminar, and I would like to sum it up what we found and how the lung ultrasound works in our hands. So to sum it up in our hands, the lung ultrasound demonstrates as a very feasible and also comprehensive imaging tool for the in vivo assessment of lung pathologies. The knowledge and also the know-how which was originally gained from the clinics can overall be applied to small animals too, as a kind of reverse translational approach, so from bedside to bench, even if we found some differences between mice and rat lung ultrasound. And on top of that, the lung ultrasound contributes to a reduction of total animal numbers, since it enables investigators to carry out longitudinal studies and to monitor the onset and progression of lung disease. And with that, I would like to thank you for your attention and would like to hand over to Sarah again, and we are happy to take any questions.
Great, thank you so much, Jana and Niklas. It was an excellent presentation. We do have questions that are currently coming in, and I'll just remind everyone to please use the Q&A button located at the bottom of your screen if you have a question for our presenters. So the first question we have is, for in vivo, do you gate your imaging with the cardiac cycle?
Maybe I can pick up on that question. So we actually do not gate the image with the cardiac cycle. So it's basically a continuous recording without gating. So something that we sometimes see, which can probably make the correct detection of lung sliding a bit problematic, is something that we call a lung pulse. So it's basically a movement that you can see along the pleural line that goes in concert with the heartbeat of your small animal. And that will sometimes definitely make the correct detection of lung sliding a bit troubling. So maybe that's a good point to pick up on and maybe try that, and maybe that will actually improve the ability to correctly detect the lung sliding.
Great, thank you. We have several questions regarding anesthesia. So can you comment about what type of anesthesia is used during these procedures?
Yeah, thank you. Usually we just use the regular isoflurane anesthesia we do with all other ultrasound techniques as well. So this would mean we start the anesthesia around about 3% for mice and a little bit more for rats. And just for the maintenance of the anesthesia, we decrease the isoflurane levels to at least 1 to 2%. So especially for the mice, we try to keep the heart rate round about between 400 and 450 beats per minute. And this should actually lead to the kind of images we showed you in this presentation.
Okay, great. So it sounds like pretty typical anesthesia levels.
Exactly,
then.
yeah.
Great. So we had a follow-up question related to that. Would you then slow the frame rates in order to get these kinds of images?
I'll pick up on that. Not really, to be honest. So we'll normally keep our frame rate constantly at above 200 frames per second. So that's basically the standard preset that we use.
Okay, so you're using the standard cardiovascular kind of setting as opposed to the general imaging setting. Perfect, thank you. So how have you validated the scoring system? Has this been done by comparing it with micro CT?
So there's the two different scoring systems that we looked at. So one is the MOLO score, which was published in 2017 by Villalba, Oreiro et al. And the second score that we did that has not been validated by CT scan or MRI. I know that Villalba, Oreiro, they have done a validation with regards to pulmonary edema, looking at wet to dry ratios of the lungs, and that correlated very well. And in general, especially the detection of B lines is known to correlate very well with extravascular lung water. So with our current investigation of our novel score, I will not give you any more details so far. You will have to wait a little bit longer since we have this published note.
Sure, no problem. Thank you. Can you tell me, do you have any experience using your method for detection of pneumonia potentially caused by pathogens such as influenza?
So let me pick that up. So we haven't done it so far. So there's a project in line we were about to start, but due to the Corona crisis, this one is a little bit delayed. So this is definitely something we want to do. And I mean, as you have seen the clinical part in the presentation, if it's the same like in humans, it should be possible to see signs of lung disease with lung ultrasound, but we haven't done it yet. And I'm not aware of any study which has done it so far. So even if it's not from us, I don't think there's one out there.
Sure. Do you think this is an applicable tool for COVID imaging in preclinical models?
Yes, probably not only in preclinical images. So there is some research going on at the moment where also the clinical departments try to apply lung ultrasound to COVID-19 patients. This is of course interesting. I'm not sure if there are already a lot of paper out there. I know that people are trying it, and I mean, it kind of makes sense, right? Because this COVID-19 patients, they display all the typical signs of lung disease, like increased lung water content, pneumonia. So it should be possible to image that, and especially for departments or clinics where CT is not available, the lung ultrasound might be a tool which is very easy to apply and easy to handle. So therefore, I would definitely agree that this is an option for the ongoing pandemic.
Yeah, absolutely. We're seeing that quite a bit popping up in the literature and a lot of webinars right now. The lung ultrasound, especially in the clinic, is being quite a useful tool for triage. So we anticipate it would also be a great tool in preclinical models as well. Can you comment, what is the smallest animal that you have used successfully for lung ultrasound? So we have a group that's thinking about using an animal that's potentially smaller than 15 grams.
So are we talking about mice, or is it, so I'm pretty sure it's also possible in tiny mice. That shouldn't be an issue if you use the right probe. But I'm not entirely sure if we are talking about mice, so.
I would assume so.
Okay, yeah, I would agree. I don't think it's a problem. I mean, you probably need to use another probe. So for mice, we usually use the 400 probe. But if you have a very small one where you don't need so much tissue depth, you probably want to go for the MX700. That's my suggestion, yeah.
Yeah, great, thank you. Can you tell us a bit more about how to translate in numbers the typical pathological features you observe in lungs? So
actually, behind these scoring systems that we showed you today, there's a different weighing of the individual pathological patterns that we see. So, I mean, you can go ahead and look at this publication by Bilal et al., and they will have very detailed information about what you can see on the screen and what that translates to score-wise. And then in the end, you will, end with an overall score, which gives you an idea. So, yeah.
Great. So we have a question. Of course, you're receiving a lot of praise during the Q&A here, but the question specifically refers to the general imaging preset, and they wondered if you had used that in comparison to the cardiology preset. And I know you said you typically use the cardiology one, but have you had any experience with the general imaging preset?
I didn't use it, to be honest, so we always had the cardiac setting. I don't know if Jana has tried otherwise, but I think we just used the...
Yeah, since we always start with the cardiac preset, we are good with this one, so we haven't tried anything else so far. I mean, all of this is ongoing research for sure, because all of this is very new to the field, because the lung was traditionally not part of the ultrasound organ repertoire. But we are happy to help, or probably also to try different pre-settings here.
Great, thank you. As a follow-up to that, the researcher is asking if you've done any 3D lung scanning.
Great question, not yet, but this is definitely something in the pipeline.
Perfect, thank you. So we did have a question that came in that I won't actually submit to our presenters, but it's regarding lung imaging and cancer models, and I'll just go ahead and field that since I'm not quite sure what Jana and Niklas's experiences are with that. But there are papers published looking at cancer models in preclinical animals, looking at the lungs, both using ultrasound and photoacoustics. So we'll be happy to send those out if anyone's interested in those. The next question we have is, have you ever tried to create a valvular model surgically and then apply this lung imaging?
You mean a valvular model for the aortic valve stenosis? No.
They're not quite being that specific.
Okay. So the model, especially the mouse model we used, is not a surgical one. It's a kind of genetic approach. So these mice developed aortic valve stenosis from their genetic background. So it's not a surgical one, because this was very important for the question if the lung ultrasound is able to detect congestion in these mice. Because with surgeries, it's always the imaging after the surgeries is always a little bit tricky. So therefore, we decided to use a model with a genetic background where the aortic valve stenosis occurs naturally. Yeah. Yeah,
great. Can you tell us a little bit about how lung ultrasound compares to chest radiography, CT, in terms of what the diagnostic value is?
Yeah, right. So this was also part of the presentation, but I'm happy to sum that up again. So the lung CT is for sure the gold standard method in the clinic so far, and most people use it, but still it's a little bit costly and also time intense. The chest X-ray has a lower diagnostic value, but is widely accepted and commonly used. And compared to that, the lung ultrasound is able to diagnose all lung pathologies, which can be also diagnosed by the traditional methods. It's cheaper and it's very quick. And I guess especially with regards to the ongoing pandemic, in unconscious patients, the lung ultrasound is probably the better tool to use, because the position of the patient doesn't really matter. So we can image the lung with lung ultrasound in any position, and the patient can stay in bed. So it's a kind of bedside approach. So it has several advantages over the traditional lung imaging tools. But still people aren't that used to lung ultrasound. So therefore we hope that, especially in preclinical research, that we can establish this a little bit more in the field and get people more used to how these images look and how to interpret those.
Great, thank you. Jana or Niklas, can you comment, do you know maybe what's the largest animal model that you could potentially do the lung imaging with the Vivo system?
So that's a very good question. So I think the largest animal that I've done this with was a rat that was about 750, 800 grams. And for that I used the regular MX250, so that worked quite well. So I'm pretty sure that you can probably also use it with some animals that are slightly bigger, but yeah, I don't know if it's already suitable like for a rabbit or something. So I don't have any experience beyond that 800-gram rat.
Great, thank you. We'll go ahead and answer just 2 more questions and then we'll wrap up this webinar. we have a question regarding lung strain. Have you ever tried to do strain validation in lungs? I know there are some papers out there that have tried this in the past.
So we haven't tried it yet. That's for sure an interesting idea, but since this technology is only starting in preclinical research, we decided to start a little bit with the basics. So to see how we can quantify the data by just looking, so do the semi-quantitative approach. I'm sure that there are some possibilities to quantify the data with strain, but we aren't there yet. So to be honest, we started with this probably 2 years ago, and it's still a long road to take. So, but this is definitely something we will check out in the future.
Great, thank you. And just as a final question here, would you actually image just one side of the lung, or would you prefer to image both sides of the lungs in one single animal?
Very good question. Something that we didn't cover, to be honest. So we would normally only do the right side, because we will experience that on the left side, you will have the heart definitely covering most of your screen, and this will definitely interfere with what you can get from the image. So we really stayed with the right side.
Great, thank you. Well, I do want to thank both of you for an excellent presentation today. There are still questions coming in through the chat, and of course we will send those on to our presenters, and hopefully we will be able to answer some of those. We see that several of you are requesting some papers for us, and we will happily send those out to you. Just as a reminder to all of our attendees, all of our webinars are recorded, and there is a wide variety of resources for you located on our VisualSonics website. In addition to the webinars, we have things like the Learning Hub, publication libraries, image libraries, lots of resources that can help you with your lung or general imaging. So please visit our website if you need more information. And again, thank you to our presenters today for an excellent webinar.